is a classical picture of the calcification within the duct of the pancreas, and this you can see the calculi on ultrasound. But my job is only in young people. That's not true. That people with FCPD always have a low BMI. That's not true. That they don't have diabetic ketoacidosis. That is also not true. And that they have less complications. Remember, the data that I am presenting is biased in the sense that it will depend on during the course of the disease, when are you seeing the patient. Pancreatic disease without the diabetes. So at presentation, there might be a situation where you find, because of some other reason, our gastroenterology colleagues see that the patient still hasn't developed diabetes. So it will all depend on who is seeing the patient, when is this patient coming to, and whom is the patient presenting to. The symptomatology will differ. And we've looked at several bits of the pathophysiological mechanism. This is our ongoing cohort. I've been looking after this for 180 FCPD people for the last 9-10 years. This is the definition of FCPD, which was described by Professor D. Mohan. Incidentally, his PhD thesis was on FCPD, and FCPD has probably changed a lot since then. So we published a series of about 8 or 10 papers on FCPD, and I'll start with the first one of it. Now, and in this entire publication set, we've compared our patients of FCPD with our cohort of type 1 in young and our cohort of type 2 in young to give you a perspective of how is this disease different from the other two varieties. So this is Diffronzo's ominous octet, and let us look at how FCPD is different pathophysiologically or similar to type 2 diabetes or type 1 diabetes. So the first thing that we all talk about is beta cell function, right? So we've looked at our FCPD cohort and compared their C-peptide reserves with type 1 diabetes and type 2 diabetes. And not surprisingly, their beta cell function is better than type 1's, but worse than type 2's. As the disease progresses, they will behave more like type 1. So the statement that the previous speaker was talking about, that they will need insulin, is true at the later part of the disease. Initially, these patients with hypercaloric pancreatic diabetes will respond to oral agents, and we'll talk about what oral agents might be suitable in these individuals. The second bit that we talk about is incretins in diabetes, and we compare our FCPD with type 2 diabetes and controls. We measure their incretins, that is the GLP-1, the GIP, and also the DPP-4 levels. Now this is pretty surprising result that we published in the Journal of Diabetes, was that in FCPD the GLP-1 levels are very high. Now that is very different from the other varieties of pancreatitis with diabetes. Now you are not expecting that the GLP-1 levels will be high. One might argue and say that the DPP-4 levels are low and therefore the GLP-1 levels are high. So that's the reason we looked at the DPP-4 levels. The DPP-4 levels were normal and yet the GLP-1 levels were high. So what are the clinical implications of this particular finding? The first thing, that these individuals will therefore not respond very well to DPP-4 inhibitors. Leave alone that in pancreatitis, you're not going to use DPP-4 inhibitors and GLP-1s. Now there is a concept of using PERT therapy in patients with pancreatitis. You are using pancreatic enzyme replacement therapy. And one of the things pancreatic enzyme replacement therapy and other forms of pancreatitis is found to have some degree of blood glucose lowering. How does that happen? We know incretin secretion is dependent not upon the amount of nutrient in the gut, but the amount of nutrient that is absorbed. So when in someone with malabsorption, you're giving an enzyme supplementation, there is more nutrient absorption, as a result of which there is increase in incretin secretion, and diabetes improves in other varieties of pancreatitis. But in patients with FCPD, if you are giving PERT therapy, we should not expect that there is going to be any improvement, because already the GLP levels are high. And one of the things that we all know is that in patients with FCPD, the risk of pancreatic carcinoma is almost 10 times higher than the general population. So could it be that this incessantly high levels of GLP-1 that is present in FCPD explains the reason why there is increased risk of carcinoma in FCPD? Now moving on to the next bit, that is glucagon. Now one of the concepts is that hyperglucagonemia is required for ketoacidosis to happen. So unless and until there is hyperglucagonemia, ketoacidosis will not happen. It's only in the early phases of FCPD, if you have a combination of low insulin with high glucagon, will you have ketoacidosis? That usually does not happen, and as a result of which usually ketoacidosis is rare but reported in FCPD. And therefore we wanted to measure the glucagon levels in FCPD and compare it with type 2 diabetes and controls. So what you can see is that in response to a glucose load, the glucagon level decreased in controls, increased in type 2 diabetes, and there was no change in FCPD. The practical implications of this is, you will see when you are using insulin therapy in patients with FCPD, many of them will not need basal insulin. Why? Because in the basal state, the glucose level is predominantly determined by hepatic glucose output. Now, if there is no glucagon, there is no hepatic glucose output alteration, as a result of which there is no hyper glucose secretion or neoglucogenesis from the liver. So even without a long-acting insulin, some of your patients of FCPD, you will see, have normal fasting glucose levels. We then looked at lipolysis, and we looked at insulin resistance and body fat, and showed that in patients with FCPD there is no increased insulin resistance. Now remember, a small proportion of our patients with FCPD will also have insulin resistance. Why is that? Because the general population itself has insulin resistance in 20 to 25%, but the rest of the patients with FCPD will not have features of insulin resistance. Moving to the next bit, that is pancreatic exocrine functions. There is a lot of cumbersome methods of actually looking at pancreatic exocrine functions. We actually looked at fecal elastase in our own lab using the ELISA, and what we found was, if you are comparing type 1 diabetes versus type 2 versus control, the FCPD ones had the worst exocrine pancreatic functions, not surprisingly. But what is important to know is that a significant proportion of them had biochemical deficiency of exocrine function without actually clinical features of malabsorption, which essentially tells us that there is a dissociation with the degree of exocrine function with the clinical symptomatology. The body adopts very well even with partial exocrine dysfunction and does not present with symptoms. It is only when someone has severe exocrine dysfunction does someone develop malabsorption. So again, the fecal elastase level negatively correlated with duration of disease and HbA1c, quite understandable, because the longer the duration of the disease was and worse the glycemic control was, it essentially meant that the pancreatic damage was more extensive. So what about the complications? So if you look at peripheral neuropathy, retinopathy, they were there in patients with FCPD as well. So to think that FCPD is a relatively benign form of diabetes and people will not have complications is not correct. And therefore you will have to screen these people just like you would screen any other patient with type 2 diabetes. Even cardiac autonomic dysfunction in our particularly older cohort of FCPD was pretty common. So we demonstrated cardiac autonomic dysfunction as well. We've also looked at periodontal disease in patients with FCPD and found that about 25 to 30% of patients with FCPD had periodontal disease, which again correlated with the glucose control, not surprisingly. So this bit FCPD have demonstrated has complications just like anybody else. What about pancreatic carcinoma? In our cohort, we already have about 6 patients who have developed pancreatic carcinoma. We've actually kept their samples, including the blood samples, the tissue samples, as well as the stones. Now, coming to the stones, we've analyzed everyone who's undergone a Frey procedure in FCPD where it was indicated. We've done a stone analysis to show the composition of the stone. But what is more interesting and exciting is this is an electron microscope photograph of the stones of our patient. And the next picture will show you it is studded with gram-negative bacteria. Now, why is this important, or what could be the importance of this in FCPD and cancer development? If you look at this particular paper, we are all worried about people with having gallstones because you say they might develop cancers. So there is a microbial hypothesis which suggests that colonization by certain specific microorganisms might actually lead to cancer formation in patients with cholelithiasis. Our cohort is still small, but we are doing a microbiome study of the stones in patients with FCPD with cancer and those without cancer to show whether there is any difference in the microbial pattern, which could probably explain why some of these patients in FCPD are developing malignancy. Now, coming to the genetic bit, this paper is currently under review. We are all aware of the genes that are involved in the pathogenesis of pancreatitis, and we've looked at the entire panel of all of the genes that are there, including all that is documented in literature. I'll just leave you with just one bit. That is, all of us know that SPINK gene mutation is associated in patients with FCPD. Now there are 4 variants of SPINK gene which are reported in FCPD. One of them is SPINK N34S. There are 2 publications from worldwide literature, one from Bangladesh and one from USA, which suggest that SPINK N34S might also be present in type 2 diabetes. Now therefore, is it that that mutation is an innocent mutation? It's not responsible for FCPD. So what we've gone and done is we've looked at our cohort of FCPD and compared it with type 2 diabetes and general population to look at all the various variants of SPINK mutation that we found. And what we have found is that isolated SPINK N34S mutation is identical in terms of its prevalence, whether you are looking at FCPD or type 2 diabetes or general population. Now therefore it could be that this mutation is a harmless mutation. It is not a functional mutation. So we've gone then and done an in silico analysis to look at the functionality of this particular mutation. In an in silico analysis, we have demonstrated that that variant is actually not functional in terms of disease. The PRSS mutation we found in some of our number 1, there is an insulin secretory defect which progresses over a period of time that the patient becomes insulin deficient. There is no insulin resistance. There is no incretin secretory defect, but there is hyperfunctioning. There is no excess in glucagonemia, resulting in no ketoacidosis and relatively normal fasting glucose without basal insulin. There is severe pancreatic exocrine insufficiency biochemically, but not necessarily clinically manifest. Isolated SPINK N34S mutation in FCPD is commonly found, not only in FCPD, but also in type 2 diabetes and healthy individuals, putting question marks against the functionality or the importance of such mutations. We found several other mutations in our cohort, but it was difficult to show a genotype-phenotype correlation. The other complications, the microvascular complications is lower than type 2 diabetes, but it does happen. Cardiac autonomic neuropathy does happen. Periodontal disease does happen, and there is high risk of pancreatic carcinoma. So we actually have to screen our patients for microvascular complications over a period of time. So I will thank all of my lab members, my collaborators, and of course the funding bodies, RSSDI national body, my state RSSDI, Indian Institute of Chemical Biology, Department of Physics, Jadavpur University, Biomedical and Genomics Center, Kolkata. Thank you very much.
Thank you, sir, for finishing well in time. The questions are welcome.
I think, Dr. Sujoy, this is really an excellent presentation, and I think the original presentation.